Don't make it awkward. On my CEs, I hate when we do CEs that's just refresher of school stuff. You got out of school for a reason, right? So, and it's because you already knew that. So CEs need to be building and growing people. So I do a lot of CEs based on case study type stuff. And this one obviously is going to be wrapped around cardiology. But there's 3 scenarios. And the purpose is when we're talking about critical thinking, it's a foundational aspect. And one of the things that we as medics screw up, or the more longevity they have, worse we get at, is paying attention from the very beginning on where we're going to start our differentials, right? So when we start our differentials, initially, everything, you tend to nail it because you're nervous. But then as you get through your career, everything is downplayed in your mind. You do not go to worst case scenario. So sometimes you're going to have these patients that sneak up on you because it switches. There's a gear that switches. So I'm going to show it in some of these. So these are all cardiac related for the most part. You'll notice when you went through them, what did they all have in common as far as a chief complaint?
Breathing.
Difficulty breathing. All 3 of them start out with difficulty breathing, right? So dispatched, 2nd Street, 70-year-old female complaining she doesn't feel well. You have 7 minutes. You can hardly get around. She can hardly get around without having a hard time breathing because her chest is heavy and she feels so weak. So that's the initial. That's what you're going to. You get on scene. There's your ABCs. Anything in that. Okay, so pulse is rapid, regular. In fact, she has a radial pulse, tells you what?
BP's up,
Right. So typical school stuff, right? What was her complaint? Shortness of breath.
And heavy chest.
What about that respiratory rate?
A little high.
What's normal respiratory rate?
16 to 20.
16 to 20, right? So the respiratory rate needs to get your attention, and you need a little bit more information. What is one tool that you have in your box now that would tell you whether this is just a nervous, anxious respiratory rate, or do you need to be concerned about that respiratory rate? End tidal, right? So if I threw end tidal on her and my end tidal was sitting at 30, what does that tell me?
It correlates with the respiratory rate.
She's probably anxious. If it's sitting at 42, is that a sick patient?
Mm-hmm.
Okay, that's a sick patient. So looking at everything from the get-go, right off the bat, when you get that first set of vitals, you need to be thinking and troubleshooting those. So our initial concerns, we just talked about that. Did she have any life threats? So was there any reason for us to intervene? So another thing I'm seeing in the field is everybody's really good at intervening in scenarios in a classroom because they're getting graded. But when we get out in the field, when I'm working with some of these experienced guys, we aren't intervening in the beginning. We aren't throwing shit on right off the bat because we're waiting to get to our diagnosis. The longer you're in the field, the more you wait to be sure what's going on before you start coming up with a plan. Your plan needs to start from the very beginning, right? So this is what you get the rest. Female, rule out cardiac, chest is heavy. Pale, cool, diaphoretic, that's kind of what we talked about. Sympathetic response. Pale, cool, diaphoretic skin, where does that come from? Why? You're right, it comes from shock. Why does it happen?
Blood's rushing to the core.
Blood's rushing to the core. So what's happening to the vasculature on the peripherals?
Constrictive.
It's vasoconstricting. Why is all that happening? What's happening in the nervous system? Which nervous system is activated?
Sympathetic.
Sympathetic response. The sympathetic response is activated. What is a visual you can get on an assessment that would confirm for you a sympathetic response is happening?
Pupils.
Pupils. What are their pupils going to look like?
Constrictive. Or
Dilated.
Dilated, right? So are dilated pupils always benzos? No. No. All right. Now, she has an allergy to codeine and penicillin. Medications, aspirin, atenolol, albuterol, nitro, history of angina, asthma, hypertension. Last day 2 hours ago, she was sitting at her desk working on a manuscript when the heaviness started. She does not receive any relief from her nitro administration, but does have a pounding headache. Anything else? Do you guys even have a treatment plan yet? Or a protocol you've picked to work?
You got ideas. I mean,
What are they?
so
ACS.
really, as far as anything, I want to say 12 week. Want to know what's going on there. Want to know for sure what a BP is, because you could go into the hypertension route, you could go a CHF route, you could go an angina route, you could go an anxiety route. It just need more info.
Okay. Well, you should be narrowed down to a direction you're headed by now, even without your vital signs. You know what vital signs are? A confirmation that you're getting it right. They're not your answer. Vital signs are not your answer. You should already be headed a direction at this point without vital signs. Your question about vital signs should be, will her vital signs tolerate nitro? Will her vital signs tolerate? That's where you should be at this point, right? So she did the typical female. She never said chest pain, right? So she did the typical female move. But you as a professional should have recognized, hey, I'm headed towards the ACS protocol here. Then she throws in the nitro. There's one of your confirmations. None of this involved vital signs. What did all this involve? All this information you got from her so far. It's way harder for the younger generation than the older generation.
Initial assessment.
Communication. Just talking to her. There was no lab test. There was no vital signs done yet. This was all talking. All right. Communication. Okay. So now you say, oh, shit, she took nitro. So we know we have some type of history with nitro. There's her vital signs. Initially, we were difficulty breathing. Whether we're going to go down a anxiety with that respiratory rate or all that, we got more information. She starts talking about nitro. She starts talking about sitting there doing nothing, working on a manuscript. So there's nothing stressful about that. And then these symptoms, and she's administered nitro. So now we went from, okay, we are going to go lean towards the ACS, right? Your vital signs, does it confirm that for you? You headed in the right direction. Yeah,
Could be.
right? What's her capnography?
36.
36 squared. So I
sign.
have bronchospasm, any sign of asthma, COPD, or any of that for the difficulty breathing? No. What was her SpO2?
Originally 92.
92%. Heart rate, 104.
And
So if anything, you should be narrowing down on your ACS, right?
the only other thing that it's going to ask with that is if the headache was before or after nitro.
Mm-hmm. And that would be a good question, because what is the headache after the nitro confirmed for you?
That's going to be from the nitro.
That the nitro's working. It's not expired. It's not messed up. It worked. So let me ask you a question here, and I'm not sure on Sanger's side. If a patient says they already took nitro, are you guys not allowed to do your nitro, or do you still do your nitro protocol, regardless if they've taken nitro, if their vitals will allow it?
We still
Still
do.
good.
Perfect. All right, so now she was describing chest pain at rest. She advised you she administered nitro. You know it's working because the patient experienced a headache. Respiratory rate is on the high end. Capnography is on the low end. Okay. High diastolic. Did you notice that? Did anybody catch that at the beginning? Why? What does a high diastolic mean?
Heart's not getting a bunch of rest.
Typically, if you were just talking, that was mainly from hypertension. What are you going to see on the systolic?
As well.
You're going to see a higher systolic too. So a 130 over 90 is, again, confirmation. You have something sympathetic going on. The first thing that happens when there's compensatory mechanisms is the diastolic jumps. The systolic doesn't move. So that's the first thing you're going to see is that diastolic bump up. Way before you're going to get obvious signs. This is minor stuff that if you're not paying attention, you don't understand what it means, it's not going to catch your attention. You're going to say, oh, she's a little hypertensive, and you're going to walk right past it. So There's your 12 lead. What do you got? Inferior MI. What is concerning also, if you look at that?
That you got a lot of depression.
Almost in every league.
So we're about to start getting worse.
So, sinus, left axis, anterior fascicle deviation, inferior STEMI, you have elevation 2-3 in ABF, reciprocal changes in your laterals. What is the big deal about axis deviation? Do you even know, or do you think it matters? Look at Willie smiling. Why are you smiling, Willie? So that's a big conversation, right? It's a big argument in EMS. Does it matter?
Absolutely.
Why does it matter?
Well, knowing where, how your electricity's traveling, where it's coming from.
So, I mean, that's how we figure it out. The only role it plays for you is it keeps you from getting sideswiped if you don't know it. So, it is a block. It is a different block from a right bundle branch block. It's a different block from a first degree, second degree, and third degree. So,
Medic 673, Rescue 671, respond to laceration at 12616 Melt Road, Medic Road, respond on EMS 2. Medic 673, Rescue 671, respond to laceration at 12616 Met Road, respond on EMS 2, Benton County clear, 907.
Baby fell and cut her wrist. Baby, it's a child, fell and cut her wrist.
Too young to be cutting wrists.
ready? So really, the point is, if you have a sick patient, they have a bundle branch, and they have a fascicle, you now have a trifascicular block. These are the people that are super high risk for sudden cardiac arrest. That's all it tells you. There's nothing you can do to treat it. You're correct. So the argument a lot of people would do in EMS is does nothing for us. You are incorrect. It does something for you because it keeps you on your toes so that you're not the one going, oh, shit, they just arrested you, didn't expect it. So I already have a sick patient. I already have a block. I add bifascicular blocks to the mix. That's somebody you just need to stay aware of. Okay, so it does play a role. All right. Onset was sudden. Provocation constant. Quality pressure 7 to 10 if you had her number it. Started an hour ago, and she's administered 3 sprays of nitro. When did she administer them? 2 hours ago. She didn't just administer these and called you. So that 130/90 is well after nitro administration. She didn't administer it and then call you, right? What's your 15 lead tell you?
She got right side involved.
No, she's got posterior involvement.
Okay.
Oh, yeah, because
Now,
V4Rs.
yes, go back to your 12 lead. What made you suspicious that, hey, I need to really be concerned about that posterior when you got to this 12 lead?
The depression.
Yes, where specifically?
And the lateral, and then the V2.
Yeah. And your anteriors, right? So anteriors opposite your posterior. When you start seeing that much depression and it carries over into your anteriors, better look at that posterior.
So your inferior amount most times will have right
Actually,
side
they're
posterior.
saying it's only like 20%
That's
of the
what it is,
time.
20%.
But still,
I look either way.
why was that different for you guys? Posterior versus inferior versus right-sided?
Why is it different?
Why is it different?
Yeah.
Why is it?
Why is it different for you? An inferior MI versus a right-sided versus a posterior?
It's good. Well, I'll let you talk about
Well, a right side can't, that's limit your nitro. You can't give nitro anymore on that aspect of it
Which is kind of a myth. Per most protocols, you can't. Do you know why?
because it drops the preload. The preload's the only thing.
And they
hard
tend to be
living
very
off of.
preload dependent.
Right.
But it is a myth that they can't tolerate it.
Right.
But most med control is going to err on the side of caution, and they're just going to say don't do it. Right. So So your STEMI protocol, 15 lead to assess right side, transmit and early activation, early transport, interventions while en route, no contraindication due to right-sided nitro contraindication due to right-sided involvement. Morphine can be considered with a systolic of 130, and fentanyl can be considered. That's y'all's protocols. That is your protocols, right? Let me ask you, what is y'all's rule or thing on aspirin administration on cardiac patients?
Give it
When?
early, quick, fast.
Yeah, it needs to be one of the first things,
Hey,
right?
you got chest
Yeah,
pain?
that's great number one.
Right?
There you go.
It is. I'm seeing a new pattern on our department. That's why I was asking. Oh, shit. Okay. Nitro contraindicated per protocol was taken 2 hours ago. Did have a headache, so it's actually working. Is that right or wrong?
Right, that she took it?
Mhm.
Yeah, that's right.
That you can come up, that basically you can establish her nitro was working, right? Aspirin, what is the purpose of it? Fentanyl, what is the purpose of it? What is the difference between administering fentanyl versus morphine on your chest pain patients? Which, yes, I'm very aware there's lots of studies coming out on the morphine.
What do you mean? Like more studies?
About
There's a lot
that,
of studies coming out
about
whether
the
or not.
histamine release
Yeah.
and everything else. I still like
I do too. But my point is, the other thing you got to do when you're talking about growing in EMS or growing in that side, if you can't tell me or your patient why you're administering a medication to them, why are you sticking it in their body? If you can't tell them why. If your answer, if I ask you why did you administer that and your answer is protocol, why are you sticking it in their body? Why are you injecting it in their body if you don't know why you're doing it? Not smart. Because that's the first thing that's going to happen when you end up in court. Is going to ask you why. So, what is pertinent information on this patient if you were calling in report that would influence continuum of care? Pertinent information, Brendan, you haven't spoke.
Well, I mean,
If you're calling in report, how are you going to guarantee continuum of care on this patient?
tell them that you found it's inferior STEMI, call code STEMI.
Okay.
You're gonna tell them what you gave, and then
Move
of
your
course you
lips,
got to put
Eddie.
that posterior involvement.
Okay. Posterior involvement.
Mhm.
What else are you going to do? What should you have done when you found it?
Called it
transmit.
Transmit. Right? So, what role do you guys play in transmission?
That's
But I mean, what role does it play for you to do that? Why do they even ask you to do that?
That way they can see it in person.
Plays a huge role, right? So you have this, we obviously think we're really good. So when we activate a STEMI, we get super pissed off when they don't activate, right? But if we're waiting to transmit till 5 minutes before we get to the hospital, or if we wait to transmit it till 20 minutes, where should you be transmitting?
See,
From the house.
As soon as you see it, as soon as you put that 12 lead on and you see it, you should be transmitting that. That's giving plenty of time for people to look at it and have that discussion before you get there. But that's also your job. That's part of you being continuum of care, making sure there is no reason for them to not have activated. Okay? Any questions on that one? So we started out difficulty breathing. Now we'll go to our second scenario. This is another one, difficulty breathing. 68-year-old male, difficulty breathing, 5 to 7 minutes, sitting in a chair, blanket up to his waist, slump over in his recliner. Kind of pertinent, huh?
this one was the one we had a lot of discussion on.
So, minimal response when spoken to only modes, airways patent, breathing, respiratory rate rapid, labored, shallow, cyanotic, audible crackles, without auscultation, 82% on nasal cannula, radial pulses absent, weak and irregular, pale, cold, dry, diaphoretic. What are you doing right now? What are you thinking right now?
Go to give him some oxygen.
Okay.
Repositioning if he's slumped over, sit him up.
Okay.
Maybe you can Get a little better breath.
Huh?
Maybe you can get a little better breathing.
Okay. You reposition, it doesn't change.
Bag it.
Do you need more information to make that decision?
No.
No. So right off the bat, what's our problems here? What's our life threats here?
He's flooded. Sounds like.
Obviously, I mean, if I
Yeah.
can hear crackles, first of all, do you truly know your breath sounds, right? Crackles and wails, where are those represented?
Deeply.
Deep, low. Ronchi, where's that?
High.
High. Ronchi is you want to tell them cough it up. Rails, crackles, that's going to be fluid, right? So I know we have something wet. Where's it at?
Low.
Everywhere, right?
Well,
yeah.
82% on 6 liters nasal cannula. That's really low on 6 liters.
Right.
Rapid, shallow. What about the
Yeah.
mental status?
It's shot. BP's gone.
What does that tell you with the blood pressure? What does that tell you? Without getting, we didn't stick no damn blood pressure cuff on this guy. What's his blood pressure?
Less than 90.
Less than 90, probably closer to 60 or 70 systolic, right? So if I'm completely missing a radial pulse, I'm less than 80. There's some people that can still have a radial pulse at 80. But if I'm completely missing a radial pulse, I know I'm less than 80.
And your carotid's weak. And so
And the carotid is not good.
Yeah.
Do I need a blood pressure cuff to go, oh shit? No. This is oh yeah, you got my little clicker. Okay. Next. So we talked about their initial concerns. So we want to go ahead and start bagging this guy. For your protocols, if you walked in on someone and you started bagging him, what all do you do? What all equipment do you need to start that process?
Your airway bag.
BB.
BBM.
BBM.
You guys do OPAs or anything? Or do you just start bagging?
I mean, we can, but a lot of times it's just grab a position airway and go.
So I have this argument right now. One, why do we carry OPAs?
To look at.
Take up room on the
So
bottom.
for one, if you have do you guys even have iGels?
Mhm.
You have iGels? So you don't need OPAs. If your patient doesn't qualify for an iGel, they're not going to qualify for an OPA. And an OPA is a dinosaur version of a tool that we have that's way more efficient. So really, if you have iGels, why are you carrying OPAs? Because I'm telling you, you guys aren't using them. So they're just for look to check off to put a box by, right? Okay, next. So no matter what else you choose, did you recognize BVM failure? Are we diagnosing this patient yet? No. But that's part of pre-hospital EMS is we've got to start addressing shit that's hitting the fan. But you'll catch yourselves getting in a habit of getting so hyper-focused on trying to figure out what's wrong, we wait to start addressing shit. Fresh out of school, that doesn't happen. Fresh out of school, these guys are jumping on the BVM. They don't care what the diagnosis is because they suck at diagnosis at that point. So it's their last priority. But experienced guys, we're seeing the difference. They're actually focusing on getting that diagnosis and they're getting late to the game on these. Okay? Did you recognize the possibility of shock? We all did. Next. So, altered mental status, only moan. So I have a real questionable GCS here. I can hear the breath sounds are shit without auscultation. I didn't even need the stethoscope. 82% on 6 is super low. Radial pulses, skin pinnacle, diaphoretic. Go next. So then you get staff noticed he was weaker than normal 6 hours ago and suddenly worsened. They advised he's normally ambulatory and self-sufficient. What does that mean to you?
Major U-turn.
That's a big difference, right? We're not talking about a guy in a nursing home that doesn't do anything but sit in a recliner.
Right.
You're talking about somebody that said's normally up walking around. He was complaining of chest pain yesterday but refused 911. Staff advised they move the patient to his chair from his bed to make him more comfortable last night, and he hasn't moved. He's afebrile. He hasn't run a fever. You move the patient to the floor, and your partner begins managing the airway. So what in all of this gets your attention?
That this isn't normal, like that he's way off from normal.
What about that complaining of chest pain yesterday but refused EMS?
Right. It's important because, I mean, then you start thinking, we're real late into a STEMI
Okay.
or something more cardiac. Obviously, you're thinking cardiac
It's
is
real
flooded and
suspicious.
stuff like that.
Yeah, it's real
already,
suspicious. Okay. They moved the patient to his chair from his bed to make him more comfortable last night. And he hasn't moved. But yet they said it was sudden onset. Right? Okay, next. Normal ambulatory chest pain yesterday, no fever, suddenly worsened, but yet we moved him last night and he hasn't moved. That kind of contradicts this was a sudden onset. Right? That's not sudden. If this normally functioning ambulatory patient, you physically moved him to the chair and he hasn't moved. Right? Okay, go ahead. There's your EKG. What are you seeing on your EKG? Interpret your EKG.
Irregular,
Irregular, so what is it?
AFib,
AFib.
high
At
rate.
what rate? I know y'all's rate is really super high. Technically, what is AFib with RVR's rate?
Over 120.
Anything over 110 or 120 is AFib with RVR. I think yours is 150, right? Before you
Sustained over
treat it.
150.
Sustained.
Sustained 150. All right. Technically, anything over 110, 120 is AFib with RVR. What is this rate?
170. Well, I mean, depending on
204.
if you count the boxes.
So, how many boxes do you need? So I did this on purpose just to see how many of you remembered how to figure out a rate.
We all argued over this yesterday.
That's a
Several
5 second strip, really.
So, you need 30 boxes. 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So count from here over times 2. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
200.
All right. Pretty fast rate. Next.
I'm surprised I said 204. But
So how would you figure this rate? Just know there's 2 ways to figure rates. On a 12 lead, how do you figure a rate? First of all, first mistake, first big problem we have is when people see that pulse ox going from 80 to 110 to 120 to 130 to 140, it cracks me up how many times I hear, God, his heart rate's all over the place. What are you seeing when that pulse ox is doing that?
The pulsatile.
Okay, so a pulse ox takes a snapshot and does math, right? So on your AFib with RVR, if it takes its snapshot right here and does the math, 100. If it takes its snapshot right here and does the math, that's going to be closer to 300, 170. So first big mistake is when you import your vitals and you just decide that's golden. You need to be looking at your rhythms on irregulars and you need to be counting them. So you need to your 30 boxes for your 3 leads. How do you figure a rate on a 12 lead? How do you get that 30-second strip or 60-second or 6-second strip on a 12 lead? Do you know? 2 columns, 5 boxes. So your 2 full columns across and 5 boxes. If you count that across, that's your 6-second strip multiplied by 10. Okay? Do that to confirm your pulses when you're comparing that to your reports. Because when you're turning reports in that show your patient was at 78 and then they were at 130 and then they were at 80 and then they were at 160, you're making it look like you're not treating this patient. Confirm those are accurate. Most of the time what you're going to find is they're not accurate. Your patient was at a rate of about 80 or 90 and you just happened to get that screenshot that was when we had 2 beats really close together. So truly the 130, 140, 160 never existed. Make sense? Okay, next. But what is your concern about this guy? So go ahead. I'm going to tell you when you actually manually checked his pulse, it was 120. Okay? I just wanted to throw that other one in there just to see. All right. Does any of this information change your differentials or your concerns? What do you think right now so far? What are you working? What are you thinking? Where's your brain going?
CHF.
CHF? Go deeper. CHF progresses to
Cardiogenic shock.
cardiogenic shock, right? That's all cardiogenic shock is, guys. Cardiogenic shock is CHF with a low blood pressure. Once they cross the low blood pressure, that is your cardiogenic shock. It's no longer CHF. Because at that point, CHF has progressed to cardiogenic shock, and it's two different treatments. Right? That's all. When people get confused about cardiogenic shock, is like, no, cardiogenic shock is CHF that's no longer perfusing. Okay? All right, so look at that respiratory rate. You have drastically improved the oxygen with the BVM. We're still afebrile. Look at that blood pressure. Is that perfusing? No. Mm-mm. Okay, next. Oh, wait. Go back. What's that capnography?
It's a little low, but not
What's
as low as I
normal?
expected it.
What's normal?
35 to 45.
35 to 44.5. So it's a lot low.
Yeah.
A little low is 36. So when we give you the normals, right, you also have to keep that in perspective. A normal range means probably in the middle. Anything on the low end of normal needs to get your attention. Anything on the high end of normal needs to get your attention. And if it's outside of the window, it's not a little something. It's outside of the window, right? What is capnography? When you're measuring capnography, what is it? Not a trick question. What are you measuring? What's that number telling you?
How much CO2 they're blowing?
CO2. It's not a trick question, Roddy, I promise. So CO2. It's measuring the amount of CO2 they're exhaling. Now let me ask you this. Where does CO2 come from?
Gas exchange.
What is it about the gas? Where did it come from, though? How was it there to even exchange? It is a byproduct of perfusion. It's a waste product of metabolism. So when somebody takes sugar and oxygen in, and the cell actually breaks down that sugar and oxygen, the feces that comes out after that meal is CO2. So when you start looking at low CO2s, guys, it's a bigger problem because their body's not making CO2. So why are they not having that what is happening that we're not making CO2? Most people focus on CO2 as a respiratory device. It tells me how they're respirating. No, it actually tells you a lot about perfusion. When I have a good CO2, I know I have a good metabolism, we're perfusing, we're off-gassing, we're making byproducts. When I have a low CO2, we're not perfusing. That's way bigger than, is it showing me bronchospasm? But if you think about it, you already knew that whether you recognized it or not, because CO2 is not just for respiratory patients, it's for cardiac patients. When you're doing CPR, what's your goal for CO2 on chest compressions? How do you know you're doing good chest compressions when you have the CO2 monitor on? What's your goal? Is it 35? Probably shouldn't be doing chest compressions on somebody if you have a 35. Huh?
About 20.
Your goal is 20. Now, right now they're saying 15, right? 10 to 15 is good quality chest compressions. So we already recognize CO2 as a cardiac monitor, or we wouldn't be monitoring it during CPR. Is that patient breathing? Not if we're doing chest compressions, right? So you already realized, whether you realized it or not, CO2 is also about cardiac. It's not just respiratory. But we start focusing strictly on the respiratory side of CO2. Cardiogenic shock, you were going. Remember I said vital signs should just confirm where you're at, right? They should tell you I'm headed in the right direction. I'm not perfusing. I have a low blood pressure. I'm tachycardic, so I'm attempting to compensate. I am increased respiratory rate before you started bagging them. Blood sugar 98, capnography of 32. That all maths. I'm not perfusing. This is cardiac in nature. So here's another thing. Did you know CHF patients, you shouldn't ever have high CO2s? If you have a high CO2 in a CHF patient, what does that tell you?
Their lungs ain't full of fluid.
So if their lungs are full of fluid, do you know CO2 moves through fluid? So it doesn't get trapped by fluid in the lungs. CO2 can get trapped by pneumonia because it's a thick mucus bacteria-filled lung fluid. But true CHF fluid does not affect capnography. So when you're like, CHF, COPD, what's their capnography? If their capnography is normal, that's not COPD. If their capnography is on the low end, that's cardiac. That's not COPD. COPDers don't have low capnographies. Right? That's your key. Okay, next. Does have a gag reflex. There's no improvement to mental status, even though you've improved oxygenation. There's all your drugs. There's your history. Last time, he hasn't eaten in a couple days. What's your concern at this point?
Get a definitive airway. We need to get the blood pressure up.
Okay. So which one? Don't straddle the fence. That
BP's
hurts.
first.
Okay, BP's first. If I
BP's
don't
your life threat
address,
because you're
if I don't resuscitate, because what have you established on airway? Before you can get an advanced airway with this information, what have you established?
that you've already helped them
You've helped
in a
him,
way.
but you haven't done an advanced airway way. You recognize you needed an advanced airway. But what have you established in order to accomplish that? What are you going to have to do?
Knock them down.
I'm going to have to knock him down. Is there contraindications to making that decision right now?
Yes, BP.
His blood pressure, exactly. That's what I'm getting at, right? That's what I'm getting at. So he needs to be resuscitated before you consider going down this intubation route, right? I've got to get that blood pressure resuscitation before intubation. Okay, next. So treatment priorities, you've established there's two you need. I need an advanced airway, but I need to resuscitate before I intubate because I got to do something about the shock that's happening here. How would you manage the respiratory status of this patient if I told you no paralytics were necessary? Kind of going along the same route we were just going.
Just ketamine to knock out your gag reflex.
So you consider your sedation route, MAI, right?
Come here, okay.
What medications would benefit this patient and why? And did your differential change from when you first started this call and walked into the room? When you first started the call and walked into the room, what were you thinking?
Just like CHF wasn't really running down. I mean, CHF's obviously cardiac, but wasn't fully thinking this was 100% cardiac in nature, thinking this was more respiratory. He's flooded. It's your regular CHF kind of, but then moving down, we're
You're
way longer
narrowing
into
it down,
this than
right?
what you.
So, what made you narrow it down? What point did you get to the point you were like, okay, wait a minute, this is way more than just that?
Part of the backstory.
Backstory, the whole no blood pressure thing, the whole heart attack possibility a couple days ago, and not calling 911. Okay, so go on to the next slide. I want to see if I ended this there. Okay, so airway management reference. This is y'all's protocol, and you're going to go. You said you needed to resuscitate before intubate. You recognize that because if I start throwing MAI crap to him right now, what's going to happen?
Good crash.
You're going to be doing chest compressions. You're definitely not going to be dealing with a 32 on your capnography, right? It's fixing to dump. So what are you going to do to resuscitate prior to intubating this guy? What is your plan per your protocols?
Push those up.
Push dose epi. Because you guys don't carry dopamine or any of that. You just have push dose epi, correct? Okay, which is not a big deal, right? So push dose epi. What is your goal before you're going to pull the trigger to, okay, it's safe for me to initiate MAI and get my advanced airway?
Try to give him
Systolic of 90,
Or
Magic
MAP of 65.
65.
Right? So they're trying to get everybody away from these magic systolic numbers and to really focus on those maps, right? So you really want to work on these maps. Some people are good at 100, some people are good at 90, some people are still fine at 80. So they're trying to get you away from the whole magic systolic number. But however, you want a minimum MAP of 65 or a systolic above 90. So our goal is not 120 over 80, right? Once we start hitting those, we're done. We're not going to push dose press somebody until we get a normal blood pressure. So when we're talking about cardiogenic shock, what organ is sick?
Heart.
The heart. And when I start doing push dose pressors, what am I doing?
Making it work.
How? What are you affecting? Brendan Scott.
Mm.
Fix to do the next scenario all by yourself.
What brings?
When I give push dose epi, what is it doing to the heart? What effect does it have on the heart?
I mean, it's like, it makes it work, but I mean, vasoconstrict.
Okay,
Makes
so
it
it
work.
vasoconstricts the blood vessels. What does it do to the heart? What's a side effect of epi?
Can make it. I mean, it can make it beat faster.
Okay, increased
Heart rate.
heart rate. That's my point. Come up with what is epi doing? It's increasing the heart rate. It's increasing the strength, inotropic, chronotropic, dromotropic, right? And it's doing vasoconstriction. So not only is it making this sick heart work harder, but it's also making it push against more pressure because it vasoconstricts the blood vessels. Keep that in mind when you're doing these push dose pressors. That's why we don't want to give them more than they need. If they get a MAP of 65 or systolic and 90, that's enough. We don't want to push it till it's not going to work. Next. Here's your EKG. Another inferior MI. Notice
This
on
one
this
is not
one,
as
if
many
you looked at your anteriors,
reciprocal.
do I have depression in my anteriors?
Mhm.
So there's a big thing, counted 15 lead, you can't tell a posterior without a 15 lead. No, they just don't trust you to, right? This guy, for more than likely, our posteriors are going to be pretty solid. We don't have any depression in our anterior leads, right? Okay, inferior, go ahead. Next. Is it froze up?
To go.
There you go.
There it goes. So, you guys had the non-traumatic shock. Position of comfort, refer to the appropriate protocol. If no evidence of STEMI, they want you to do a bolus. If no response to bolus, consider your push dose pressor. So you're right on cue with what your protocols are doing next. RSI, once I get that up, there's your RSI protocol. Ketamine and Versed or etomidate. Then you guys go to Rock or Beck, and then continued sedation.
Yeah, he actually took our PAI protocol out. He's right.
Do what?
He actually took our PAI protocol out.
So this
That we
doesn't exist
had.
anymore?
No, that's the RSI protocol.
Oh,
It's just,
He took it out, but you just got
But-
a call to get it.
okay.
It's still there. You just got to go, hey, this is what I'm doing, why I'm doing it. They'll go,
Is your PAI pretty much this without the
yes, ma'am.
the paralytic?
Mhm.
That's pretty much all you need then, right? Because, so let me ask you this question. If you chose to go down this protocol, since you don't have the PAI protocol, and you got through the first step and you were able to innovate, do you have to push the paralytic?
I'm going to innovate them. If I get them knocked down with etomidate,
My point is, do you really need an MII protocol if you have the ability to recognize, well, shit, I don't need the paralytic. He's out. And he's tolerating it fine, right? What is reasons for paralytics? Now, I take that back. There are some studies now saying you should be pushing it, period, after you get an advanced airway. I get that. But what is the purpose? When do you start recognizing sedation isn't enough? Obvious gag reflex.
Buck in the tube.
Buck in the tube, trying to fight
That's
against
right.
you, breathing over the tube, right? Okay. Next. So you successfully managed the respiratory status. You've improved everything. You've resuscitated with epi push dose pressors. So the biggest thing about this one wasn't so much were you going to get the diagnosis right. The biggest thing about this one was going to see, before you even knew the diagnosis, were you going to recognize I have to resuscitate this guy before I start going, or were you going to rush into the intubation? He obviously was going to need intubated. He's moaning, his respiratory shit, his breath sounds are shit, his SpO2 was shit, You knew he was going to have to be intubated. The purpose for this one was to see, were you going to recognize if you jumped in that hole before you jumped in the resuscitation, you're going to end up with a code. You're going to be doing chest compressions. That was the purpose of this critical thinking. Okay, go ahead. Next. STEMI protocol next. So, AFib, here's the other thing. Were you going to jump into the possible AFib with RVR?
Yes.
If we told you the rate is 120, and we truly had a systolic of 70, is it AFib with RVR, or is that just AFib with a compensated rate?
I think it's AFib with a compensated rate.
Yes. So the other risk of this one is people that are very textbooky and very 1, 2, 3 are going to go down the rabbit hole. They're going to miss the cardiogenic shock, and they're going to say it's symptomatic AFib with RVR.
That's what I did if it was at a rate of 200.
Yes. But I remember I dropped it to 120,
Yes.
that first one. So 120 AFib with RVR doesn't meet your criteria. Let's even say it was 150 AFib with RVR. Really, with the diastolic and as sick as he is, you need to fix some of that first and see if that rate comes down, because you might be looking at a compensatory rate in a patient that has AFib. That's no different than you having sinus tach when you go into shock, but your underlying rhythm sinus tach. So we got to be really careful. You're going to see AFib with RVR patients on your sepsis patients, any of these shock patients, and if you chase that AFib with RVR and do not catch that AFib with RVR is a compensatory rate, and you push this cardizem to knock that rate out, what's going to happen to this patient?
Their BP's going to drop.
You're going to be
The
doing
only
chest
reason their
compressions.
BP's up is
You're
because
going to be
the
doing
heart
chest
rate's up.
compressions. So this one threw several things into the mix, right? We threw the AFib with RVR in there to see if you would chase that rabbit hole. We threw the, hey, they needed an advanced airway to see if you would chase that rabbit hole. And really, if you didn't focus on the low blood pressure rabbit hole and do the resuscitation, all those other decisions you would have made with AFib with RVR and all that, you would have been doing chest compressions on this patient. Period. All right. Next. Last one. Again, what's the chief complaint?
Difficulty breathing.
Difficulty breathing. Dispatch, Cherry Street, 58-year-old male, chest pain and breathing difficulty. Your response time is 5 to 7 minutes. Next. You find patient sitting upright in chair, 1 to 2 word dyspnea, productive cough, gotten worse in the last 2 hours. Alert and oriented, airways patent, rapid and labored audible rhonchi and wheezes. What is rhonchi?
Mucus,
Where?
uppers,
When it's wheezes?
Lower.
constriction, bronchoconstriction.
Bronchoconstriction. SpO2 at 88% on nasal cannula. Radial pulses are rapid. What do you get out of radial pulses are rapid?
Got higher heart rate.
Heart rate's fast. What else can you get out of that?
Blood pressure's systolic, or at least 90 systolic.
Yeah, blood pressure's decent. I don't need a blood pressure cuff to tell me I'm not overly concerned about a blood pressure here. We have radial pulses. All right, next. So what are you thinking so far, just out of what you got? Funny thing is, when you do classes like this, a lot of people don't want to answer and they don't want to participate. Why?
Don't be wrong.
Don't want to be wrong.
Stupid.
Don't want to be wrong. But here's the thing. If you got everything right in your life, how would you grow? So growth comes out of failure. So when you screw something out or you throw a wrong answer out, you're actually getting growth out of that. So this whole thing, it's funny how we do that to ourselves, that we don't want to answer because we don't want to be wrong, when actually we benefit more from being wrong than we do from being right. You get it right, you stick your chest out, you poke yourself on the back, and all's good. You get it wrong, you're like, oh, and you fix it. Right? Okay, so at this point, all the information you have, what are you thinking?
You could be,
Because you should be thinking.
you could be leading down the COPD route.
Okay. It's good seeing you.
Medic 673, Rescue 671, respond to a sick person at Family First Automotive. Respond on EMS 2. Medic 673, Rescue 671, respond to a sick person at the Family First Automotive. Respond on EMS 2, Benton County clear, 945.
All right. So my point is, you should be thinking at this point, right? It's when we decide not to think till we get vital signs that you end up in trouble. So I don't know. Am I going difficulty breathing COPD respiratory side? Am I going difficulty breathing cardiac side? I need more information, but you're going difficulty breathing.
Right.
Next. They have 2 inhalers sitting at the end of the table. Stated they have not helped him. Patient has a history of emphysema, has at-home oxygen, has taken puffs of his inhaler in the last 30 minutes of albuterol. So, what direction you going?
COPD exacerbation.
Start thinking more on the COPD side, right? I'm going to think respiratory. What information could I acquire now? So your patient assessments should always have a plan. It shouldn't just be, I do my patient assessment this way because that's what the checkbox says. Your patient assessment should be directed based on your differentials and what you're doing as you're thinking, right? So I'm already thinking, what would be an awesome piece of information at this point right now that would confirm or deter your direction?
Waveform.
Waveform, end-tidal waveform, right? So if the waveform's high, what is that going to tell me?
COPD, they're tracking.
I'm tracking respiratory here. We're retaining CO2. If it's low, what is that going to tell me?
Cardiac.
This is cardiac. This is not respiratory. So when people, this blows my mind why people confuse CHF and COPD. And it has to boil down to basic education. It has to boil down to, at some point, somebody did not explain the difference or the value of CO2 in these patients, or you would never be screwing it up. What's the same complaint? Difficulty breathing. That's what screws us up. Their description of their symptoms what screws us up. It's 2 different organs. So the biggest key is, do you understand CO2? Then you will never screw those up. So people say, well, Marta, you can have cardiac wheezes. That is correct. What do you think their CO2 is? Wow. So just because you hear wheezes doesn't mean it's bronchospasm, guys. If it's truly bronchospasm, COPD wheezes, what should your capnography be? High. You should be trapping CO2. If you're not trapping CO2, that's not respiratory wheezes you're hearing. You're hearing cardiac wheezes. All right. I had to throw this one in there. Which block is this?
Second degree type 2.
Good job, Bubba. Second degree type 2.
I won't take all the credit for that. We looked at this for a while last
So, on your blocks, the key is your PR interval. Okay? The only ones people, you know your first degrees, you know your third degrees. Right? Why are you slow to answering me?
Oh, yes.
Okay.
But
yes, I know. Say it with confidence. Balls drop, chest out. Yes, I know what a third degree is. Okay. So, the only ones that get confusing for people is the type 1, type 2, second degree. Are your PR intervals regular? If your PR intervals are regular, it's a type 2. If your PR intervals change, it's a type 1. So when people teach that whole winky bop, longer drop, you will screw up. Not all of them look like that. So the key is, once you establish you have a second degree block,
2010.
once you have a second degree block, once you've established, this is not a first degree, it's not a third degree, you go to your PR interval. If your PR interval is the same all the way across the thing, it's a type 2. If this was a type 1, you would see PR intervals that change. That's the difference. That's how you tell the difference between a type 1 and a type 2. Screw all that other mnemonic shit people try to teach. Is my PR intervals regular? Because if they are, it's a 2. If they're not, it's a...
So if they're regular, are they going to be prolonged?
Doesn't matter. It doesn't
Then
matter
can
if
they
your
be?
type 2 is prolonged. It doesn't matter if they're within normal limits, outside of normal limits. It's totally irrelevant. That's what screws people up, is they want to say, okay, but in this, for example, this one, they want to say, but the PR interval's normal. I never asked you if it was normal. I said, is it consistent? Does it change? So some type 2s can have a normal PR interval because they have a complete block in that one area. So they're just missing a QRS. So you're not worried about, is the PR interval prolonged? You're not worried about, is the PR interval short? You recognize it's a type 2 because it's not a 1 or a 3. Is my PR interval consistent? Is it too long throughout the EKG? Is it too short? Whatever. It doesn't matter whether it's in limits. Does that make sense? It's just, is it consistent? Okay, next. Wow. Oy. Okay, so that's how we ended up. That is the 12 lead of that. And I even was able to find a second degree type 2 12 lead so that I could carry that along. Anything in your 12 lead?
You got higher voltage in your V2, 3, 4, 5, and 6, but
Which, how would you interpret that?
you QRS number.
But I mean, what would that mean to you?
If it's over 120, they got a
No,
bundle.
you're talking about voltage. You're not
We're
talking about
talking about
width.
height, not width. So blocks is width. So this is just, you could be looking at some LVH or depending RVA, right?
Mm-hmm.
Okay. Anything else that jumps out to you on this 12 lead? Funny thing is, you know why nobody wants to answer this question? Because they don't see anything and they don't want to say no and be wrong. Am I correct? All right. No, there's nothing to freaking see. Okay, next. Nobody wants to answer except, oh, surely she stuck something in there. This is not a trust class. What do you see? Marty, I see nothing. You are absolutely correct. Move on. The block. You still see the block. That's it. If it lets us move on.
That was
So what protocol would you consider? What medications would this patient benefit from? So back on one of those slides that it was all jumbled up, it gave us vital signs, and I'm pretty sure I had the capnography at like 42, 45 up on the higher end. What would this patient benefit from?
Duonem, steroid. Start working your exacerbated COPD.
Do you guys carry Duonem and albuterol?
No, man.
So you
Duonem.
just carry
Duonem.
Duonem. Okay, never mind then. New conversation. So what happens? So why would they benefit from the albuterol
Help
or
open
the Duonem? Which actually, what is Duonem?
It's albuterol and ibuprofen.
Albuterol and ibuprofen. So why do they benefit from the albuterol?
Dilation.
Bronchodilation. It is a beta 2 agonist. How do they benefit from the ibuprofen?
Spasms.
Mucolytic.
Oh, yeah.
The mucolytic. And it helps bronchospasm, but its big thing is it's a mucolytic. It breaks down mucus. So what else could they benefit from? What is your protocol? What protocol are you picking?
Difficulty breathing and then COPD exacerbation.
Going to the COPD. What confirms your COPD?
High and tidal.
High in tidal, wrong guy, got the sputum, got the inhaler sitting next to us, so we have a history of it. We're on home oxygen. We have emphysema. What does she look like if she's probably emphysema patient?
Barrel chest.
Barrel chested, pink flesh skin.
Red puffer. Pink puffer. Pink puffer.
Why is she puffing?
Because she's trying to keep
What's the
Great
pierced
knee.
lips for?
She's making
Great
her own
positive
pee.
pressure.
She's doing her own CPAP.
Mhm.
She's creating her own CPAP, right? She's creating pee. Okay, next. That's your protocol. You got, what is the purpose of the steroids? Why do you do methylprednisone?
Is that the new one?
No, that's
Ooh,
I
Decadron.
don't know. It's one I got.
When did I give it to you?
A while back.
Drug out process.
Okay, yeah.
yeah. 'Cause now it's
And I might have two, because I think I was given one, so I might not have even opened the recent one you gave me, because I already had one. So let me double check.
Some stuff.
So this is an old one, I'm guessing.
Decadron and then you add Trebulin.
So Decadron and Trebutaline's added in here?
Yes.
Okay. So what is the purpose of the Decadron?
To suppress the
Anti-inflammatory.
Immune system. What
suppress
is
immune.
what is an inflammatory response?
Mucus.
So
and the
the
body
cytokines
overreacts.
and all that has fluids and all that stuff rushes to an area and creates inflammation, right? We're trying to block some of that. What is the purpose of your terbutaline? Because gosh, dang it, we love it.
Smooth muscle relaxer.
Smooth muscle relaxer. So what other protocol do you see terbutaline? Well, I don't know if you do. What would be another protocol you would see terbutaline in that has nothing to do with breathing?
Pregnancy.
Pregnancy, preterm labor. Smooth muscle relaxer. That's the reason you give breathing. It's a smooth muscle relaxer. It also relaxes the uterus. Right? All right. Chest pain is only present when patient coughs. You treated the COPD presentation of this patient. Initially choosing chest pain protocol would have been fine because that's what the patient initially was kind of leaning towards. But you didn't have enough info to rule it out initially. So you should have never completely decided, oh, they have difficulty breathing, I'm doing the COPD. I needed to confirm with my 12 lead that I was ruling that out. Because here's the thing. So you can't just say I ruled it out with the bronchi and the low SpO2. Because then you're basically telling me COPD patients don't have heart attacks. Every COPD patient has horrible SpO2, difficulty breathing, and mucus. So you got to be careful with these difficulty breathing COPD patients to jump onto that COPD exacerbation and stay there. Okay? So always rule out your cardiac on your COPDers through your 12 lead. Okay. ASA would possibly have already been administered to this patient. What were they complaining about? They said chest, right? So if you would have dumped aspirin on this patient initially, that would not have been a tag. Because when are you supposed to dump aspirin?
Hey, you got chest pain? Here, chew these up.
Now you need to be careful if they say it's one of the patients. What is y'all's contraindications for aspirin?
I've already taken their 324 of aspirin.
If they've already taken it, right?
Or if they're allergic to it.
Brendan Scott, if they're allergic to it, you probably shouldn't be getting it. All right, next. All right, what'd you think?
So that. Dang it, I lost my thought. Go ahead.
Parsons. So, was it cardiogenic shock where Dr. Basil doesn't want us using push dose? Is that what he brought up? I think it was CHF and
He will
cardiogenic
say
shock.
you got to be careful. I will say you got to be careful.
Because you're putting extra workload on the heart.
The heart's
I
already.
think one of his recent studies, and that's why
Yes.
he was pulling
That's
it
why I
out.
wanted to really push. What is your goal with that epi push dose?
Right.
Because
That's
you're
right.
already dealing with a sick patient.
But then if they're CHF, they're already full of fluid. You don't want to fill them with fluid to bring the pressure up either.
Now, the whole thing of you cannot give CHF patients fluid is a myth. So
Just gotta
the
watch.
fluid is not, you're not giving it in their veins. They have a fluid shift happening, and they've lost some of their vasculature fluid because it's leaked into the other. So this whole concept of I can't give CHF patients fluid because I'll drown them is not correct.
That's why you do your like bolus.
They tell you a bolus of 250, reassess
Or-
before use, right? So that whole, when we tried to make everything black and white in EMS so that everybody could pass the test, we screwed shit up. Because when we made it black and white, we quit thinking. Because we decided everybody fit in this box and everybody fit in this box, and that's not true. They do not all fit in the same box. You've been doing this long enough to see. One CHF patient does not look like another one, right? And sometimes COPD and CHF can look very similar.
And sometimes
Truly,
they have lumps
sometimes
out.
the
Maybe
only
just normal lumps out.
true way of figuring it out, guys, is that
Pull the trigger.
capnography.
Well, yeah.
Because a true CHF patient, by the way, also has a square waveform. Your COPD patients, if it's truly COPD, they're going to have high. If they have low, if COPD has a low capnography, guys, that is cardiac. That's not their it's a COPD patient having some problems with cardiac. And then it drives me nuts if they say, well, they didn't have a history of CHF.
They don't have to.
There's always that first diagnosis, guys. It comes from somewhere. The initial diagnosis came from somewhere. So there is such a thing as they didn't have a history of CHF. So basically, when you say, well, they didn't have a history of CHF, you're telling me until a doctor corroborates this and gives them a history, I'm not treating them for anything. Unless they have a history of it. They don't jump on board. Right? No, that's not how that works. Any questions? Feedback
I was still on the fence on the last one.
on the COPD? Well, there was a screen we couldn't see that gave you a lot more information.
I think the screen, that's what got me more on the fence, though, was the screen before.
History of CHF and
I gave him both.
COPD.
I gave him.
Medications that he's on. The fact that he did take his breathing treatment with no relief. Even though
But
And
what
it-
did it say he took?
albuterol.
Albuterol.
Just albuterol. But, and then I was thinking, I don't know, and then vitals, blood pressure was 160.
Mm-hmm.
So we're up there. Does have a history of hypertension, but on,
Didn't I keep the diastolic around 90?
Like
though?
160 over 80 or something.
60
160 over
over 80.
90,
We kept the
something like that.
diastolic low. The biggest one on that one that would have helped your, okay, we're going to go down the COPD route, was I gave you a 12 lead that was clean. And I gave you a capnography that, if I remember correctly, was on the high end of normal.
I feel like it was like 48.
So you could have, you may not have liked it, but you could have said they are perfusing.
Yeah.